Today, I'm very happy to welcome Dr. Jasmine Zapata for Grand Rounds. She earned her medical degree and then did pediatric residency here at UW. And while doing her pediatrics residency, she also earned a master's in public health as part of the preventive medicine residency program. She's now an assistant professor in the Department of Pediatrics and Population Health Sciences. And you may have also seen her across the room at some of the deliveries at Meriter as she works as a newborn hospitalist. Dr. Zapata has extensive work and research in community-based solutions to maternal child health disparities, community program development in mentorship and empowerment. I could go on, but I'd rather just have her speak this morning. So please virtually welcome Dr. Zapata.
I'll never forget getting a page as a resident and running down to the emergency room at Meriter, where we heard that there was a newborn baby who was just born hours prior, who had been rushed to the emergency room. The mother was critically ill and the baby was there. When we ran in the door, they were doing chest compressions on the baby, and I'll never forget my heart racing, and they asked me to come give compressions. As I was giving compressions on this little baby, I'll never forget, out of the side of my eye, seeing the dad there in horror, looking on and crying. After a few minutes, we determined we could not revive the baby. And I'll never forget the nurse placing the little baby in the dad's arms as he audibly sobbed. At that moment, I felt so helpless. All I could do was rub his back, but I knew there was nothing more that I could do. I'll also never forget the time I got another page and had to run down to the delivery floor. There was a mom who went into labor at only 26 weeks. The baby came out. Instead of crying and being vigorous, the baby was limp and pale. Again, my heart was racing. I'll never forget them bringing the baby over to the resuscitation bay and us not being able to get the heart rate above 60. The baby had to emergently go to the NICU, and I followed up to the NICU to see what was going on. And they asked me, they said, "Jasmine, we need you to go back downstairs and get this mom. This baby's not going to survive. She needs to say goodbye." I'll never forget that walk down the stairs to go tell this mother this news. Who am I to deliver the news of life and death to a mother? It was heartbreaking, especially because I knew that just a few years prior, I delivered a critically ill premature baby as well. It was the hardest conversation to have with this mom. I'll also never forget getting a call at 2 a.m. from a friend from church saying that her daughter-in-law, a young Black woman, went into labor prematurely at only 22 weeks. They asked if I could come to the hospital as a friend. And I remember rushing across town to get there. And when I walked in, the emptiness in that mom's eyes was heart-shattering. I remember sitting there just praying with her, talking with her, trying to give her any hope that I could, but deep down in the bottom of the pit of my stomach, I knew there was nothing they could do. When I left the hospital, I went home. It was hard to sleep. And then I got a dreaded text just a few hours later that the baby was born and only lived a few hours. I'll also never forget getting a call that my own cousin went into labor, a young Black woman, at 22 weeks. And I remember my family was hopeful, saying, "Oh, they'll just take the baby to the NICU. Let's pray, it's gonna be okay." And I said, what gestational age is the baby? And when they said just barely 22 weeks, my heart just sank. And a few short days later, that baby passed away too. Right now in Wisconsin, Black babies die at 2 times the rate of white babies before they reach their first birthday. Right here in Wisconsin, college-educated Black women have a higher chance of preterm birth and adverse birth outcomes compared to white women who are high school dropouts. This is a public health crisis that cannot be ignored, And that is why it is a tremendous honor to be here today for OB-GYN Grand Rounds to talk about this important issue. I am beyond excited and honored to talk to you today about my personal and professional journey toward combating racial inequities in infant mortality. A little bit about me. Thank you for that warm introduction earlier. I am a proud newborn nursery hospitalist. So I am a pediatrician, and also I am a board certified preventive medicine and public health doctor. So it's just so exciting to be here. Outside of my work at Meriter Newborn Nursery, running to deliveries, doing resuscitations, treating healthy, well newborns, outside of that time, I do a lot of research on ways that we can prevent racial inequities in infant mortality. And that upstream lens brings me into the world of OB-GYN and even into women's childhood, because we know that a woman's birth outcomes are impacted not just by what's going on during pregnancy, but what is going on over the course of their entire lives. So I just love the combination of pediatrics, prevention, and public health. I am also a mother of 3 beautiful children that keep me alert and active. You might hear some of them in the background, but just try to tune them out if you do. But I love my family and my kids, and I love talking about this issue. And so it's an honor to be here today. My goal of our talk today is to do 3 things: to talk about some statistics, to tell some stories, and then also to focus on solutions. So there's nothing that's going to stop us. No technology issue, no other thing, nothing is going to stop us from having this conversation. So I'm so excited to be here and that we overcame our tech issues. So let's start with some statistics. I'll never forget a few years ago when I saw this map and saw this statistic, just being blown away. Infant mortality is defined as live-born babies that die before their first birthday. Again, live-born babies that die before their first birthday. And right here in Wisconsin, compared to the nation, Black infant mortality rates are the highest in the nation. If you look here at Wisconsin, we have the highest Black infant mortality rate. Now, when you compare our infant mortality rates, when you just combine all races, Wisconsin is comparable to the rest of the nation. But when you separate it out by race, Wisconsin is known for having the highest Black infant mortality rate. That is definitely a problem, and that drives a lot of the work that I do. Let's dig into the statistics a little bit more. In 2019, Dane County, Dane Madison Public Health Department put out a maternal and child health data book. It's really helpful. I am on the Fetal and Infant Mortality Review Board here in Dane County, where community members, mothers, healthcare professionals, public health physicians and nurses all come together. And what we do is we review the last quarter, and we review all the cases of babies that died before their first birthday. We look at their medical records. We look at interviews with the mothers. We look at the autopsy reports, the social work records, and we review those cases collaboratively, and we work to come up with solutions. And so this data is very important because it can help us find root causes and really understand how we can find solutions. So let's just talk about these statistics very quickly. I don't like focusing a lot on the negative, but in order to really solve a problem, we have to know what our enemy is and what we are working with. So infant mortality rates among Black infants have been higher than rates among white, Hispanic, and Asian infants since 2008. And some data that's actually hot off the press, we actually were able to get some of the preliminary 2020 data. This trend continues. If you notice, these blue dots here represent Black infant mortality rates, and they are significantly higher than white infant mortality rates. Another very interesting trend to realize is that the Latinx Hispanic infant mortality rates, if you notice this trend, they're slowly creeping up over the last several years. Now, I want you to just, as I'm showing these statistics, I want you to be thinking about why. Why is this the case? What could be going on? This also shows right here in Dane County, our infant mortality rates. And just notice some trends. Interestingly, the white infant mortality rates have been going down just a little bit. Our Black infant mortality rates compared to 2008 have been going down slightly, but compared to white infant mortality rates, that is a huge difference, okay? And then the Asian infant mortality rates have been going down, which is encouraging. And then the Hispanic infant mortality rates have gone from back in 2008, 4.3 per thousand, all the way up to 11.6. Now, this data from 2020, it needs to be interpreted with caution because this is very preliminary data that's coming out and it only goes up to about December 4th. So it's going to change a little bit, but in general, we can see these trends. Now, I want to talk about some of the root causes for infant mortality. Why are these babies dying before they reach their first birthday? Many places I go, a lot of people think it's due to SIDS or unsafe sleep, but the leading cause of infant death before the first birthday is complications of prematurity, preterm birth, low birth weight. And again, we see a trend. Preterm birth rate among Black infants has been significantly high compared to other races over the last several years. So complications of prematurity, Black women having babies born too early and too soon is what's leading this infant mortality crisis. So again, I want you all to be asking, why? Why is this happening? This is some national data from the CDC. And basically, again, it shows that what's happening in Wisconsin is in line with what's happening nationally. The number one leading cause of infant mortality, especially in African-American infants, is low birth weight, premature babies. Here is some hot off the press data from the public health department as well, right here in Dane County, where it shows that, again, low birth rate among African-American babies has been significantly high, and there have been no significant changes over the last several years. So again, this is an inequity. Now, a lot of people interchange the words disparity with inequity. A disparity is just when there's a difference that you see. So for example, traditionally, there are, on average, men are taller than women on average. That's a disparity. But is that something that we need to fight for? Is that something that needs to change? Is that a social justice issue? Some may argue, yes, it is, but in general, it's just a difference. That's a disparity. And, you know, we're not trying to go out and change that. But when you see a disparity that is due to things that we have the power to change, that's due to things that are not right and that are unjust, that is called an inequity. And this, what we're seeing right here, what this data is showing, is an inequity, a racial inequity in our infant mortality rates and our preterm birth rates. And so this is a public health crisis that we can't ignore. This is as serious as COVID-19, as serious as some of the other things we're talking about. And I know I'm preaching to the choir because I'm talking to an OB/GYN audience, but this is something that has been a problem for many years, and we're not seeing any serious change. So we need to continue to bring awareness to this topic. And again, this is just showing our data that includes 2018 to 2020, that our preterm birth rates among Black babies is twice as high as white babies. And so now let's dig into this a little bit more. We say that what is driving these infant mortality rates? Again, this infant mortality crisis that we're facing of Black babies dying before they reach their first birthday. They don't even have a chance at life yet because they can't even reach their first birthday. We have discovered that it's due to complications of prematurity and low birth weight. So let's talk about that a little bit more. Let's talk about some complications of prematurity. What goes on when a baby's born too early and too soon? There are many acute and chronic conditions that they can face. And in order to bring this alive, because I know you're tired of hearing about statistics right now, I'm going to now share some personal stories. I want to talk to you about my personal NICU journey. All of those statistics that I mentioned are so near and dear to my heart because I was one of those statistics of a college-educated Black woman having a higher chance of an adverse birth outcome compared to white women who are high school dropouts. And it's so scary because we know that the number one cause of these Black babies dying is complications of prematurity. And I was almost that statistic. So I'll never forget, it was September 20th of 2010, and I was walking to the HSLC. I was walking to medical school. I was a second year medical student. I was so excited because I was pregnant with my second child. I got married super young. I dated my high school sweetheart when I was 16 years old. We got married when I was 19. While I was in college, I had a first child my senior year of college, a natural delivery, no pain medicine. I was so proud of myself, and all natural. And oh my gosh, guess what? I went back to my college class. I had the baby on a Friday, my first child, and I went back to class on Thursday of the next week. I went to night class because I was like, nothing's going to stop me from graduating because I got accepted into medical school. So let's pop this baby out and let's keep it moving. I could not do that again now, but that's what I did. I was in my young 20s, healthy and flexible. But anyway, I started medical school with the new baby in my hand, and then I got pregnant again during second year of medical school. And I was so excited because I had previously had a boy, and now I was pregnant with a little girl. I was due January 2nd, but then on September 20th, I felt a sharp pain in my lower abdomen. Now, I knew what contractions felt like because I had had a natural delivery before. This wasn't contractions. It was just kind of like a sharp pain in my lower abdomen. And so I went to class, and I remember sitting in class. It was a cardiology lecture. I'll never forget that because it was already hard enough to focus. And especially that this was happening, I really couldn't focus. So I went to the bathroom. I just thought it was gas, and it didn't go away. And so I went to lay down in like a special area for mothers. And I lay down on a couch. And I remember saying, oh, this sharp pain is not going away. So I called the nurse triage line with my doctor, and they said, oh, it's just Braxton Hicks contractions. You're fine. Just lay down and drink some water. So I said, okay. Now, mind you, I was just a second year medical student. I wasn't in, clinical practice yet. And so I just said, okay, Braxton Hicks contractions. So I went to lay down, and it was still there, just a sharp pain. And I called again, and they told me the same thing. And they said, but if you notice any blood, then, come in right away. But this is just Braxton Hicks contractions. You're just stressed out. Just lay down. So I lay down another hour, and I still felt that sharp pain. Then I went to the bathroom, and to my horror, I saw bright red blood. And so I rushed and I ran from the HSLC to the emergency room at UW. But I knew that UW doesn't deliver babies. And I called an ambulance on my way, running myself to the emergency room. And I said to the ambulance, meet me at the UW emergency room. I need to get over to St. Mary's, because that was my delivery hospital. So I ran to the emergency room just so I could be somewhere to get some help. And I'll never forget, they checked me and they said, oh my God, you are 10 centimeters dilated and your bag of water is bulging. And right when they said that, they said, oh my gosh, oh, what? There's an ambulance here to take you over to St. Mary's. I was like, yep, thank you. My ride's here, because I knew it was going to happen. I jumped in the ambulance. They rushed me over to St. Mary's. And when I got there, they told me, they tried to stop the labor, but they said, you're going to meet your daughter today. And when they said that, my heart fluttered, because it's been my dream my whole life to have a little baby girl. But then that happiness for a second turned into deep despair and a pit at the bottom of my stomach, because I knew it was too early and too soon. I rushed to the C-section. I had an emergent C-section. Luckily, I was able to stay up, but she was transverse, so I had to get a classical C-section, and my husband got there right in time. And when she came out, it was silent in the room. No screaming, no crying, no happy moment of reunion where I get to put her on my chest. She was quiet. And they rushed her away to the NICU. So as we were talking about, so that's a little bit of my story. Let's continue as I go through my story, talking about some of the risks that babies face when they're born too early and too soon. What are driving these infant mortality rates? These babies can have respiratory issues. So this was her hooked up to a ventilator. And this was my mom and my older son getting to see her for the very first time. This was me getting to hold her for the first time. It's an amazing thing to get a hold of baby right away, but she was so critically ill, I didn't get to hold her for 2.5 weeks. This was on my birthday that I got to hold her for the very first time, because it was the first time she was stable enough to be held. These babies also face many gastrointestinal and nutritional issues. They can have something called necrotizing enterocolitis, where their gut can have some serious issues. And a lot of times, if medication can't help that, they have to get surgery, and they have to get removal of parts of their bowel. It has a very high mortality rate. So that was something that these babies who are born so critically ill and so early face, that can then lead to those infant mortality rates. I was blessed because she did not have that complication. And one of the things that can help prevent against that is breast milk. And so I was so blessed. This is me just so excited, holding my first little colostrum and being able to give that to her. Now, as I'm talking through my story, I also want you to be thinking about my experience as a Black woman who I would say I was privileged. I was in the medical fields. I also had a partner, a support partner. But I want you to think about some of the other Black women who are living right here in Dane County that might not have some of those same resources. Also, right now, we are seeing that there are high inequities in the number of Black women who are breastfeeding. So that is an issue that's out of the scope of this exact conversation, but that we need to be working for and advocating for as well. But anyway, this is gastrointestinal and nutritional issues are serious complications that these little babies can face. These babies can also face thermoregulatory issues and problems with their skin breaking down, which can introduce infection. This is just a picture of her holding my finger. It was so tiny that her whole entire hand just fit over the tip of my finger. And that's just a picture of it again. Now, this was so hard for me because as a mother, especially as a Black mother, I was so excited to have this little baby here. But I felt guilty inside because in these first few moments, I couldn't give her my full love because I didn't know if she was going to live or if she was going to die. There were many times I would get a call in the middle of the night with them telling me, you need to get here. Things are kind of rocky right now. We need you to get here, bring some family with you. It was very, very scary. And just a few years prior, when I was in college, I actually had my 16-year-old brother die suddenly in his sleep, which was very traumatic for our family. And so our family was just healing from that loss. I didn't want to bring a little child into this world and make my family go through that again. I had to also protect my heart because I didn't want to embrace her and fully love her and then she die. But then that made me feel so guilty and horrible. I'm supposed to be her mom and love her, but I'm torn because I don't know if she's going to survive. It is a very challenging situation. But she kept fighting. She kept taking one day at a time. This is her, so tiny and so fragile, just right under my hands. These babies, again, also can face cardiovascular and hematologic issues. Oftentimes, they need multiple blood transfusions, which she did. They can also face many neurologic complications. And one thing that can happen is they can have brain bleeds. Interventricular hemorrhage is something that she had. And I'll never forget I was still trying to study my medical school studies to keep my mind off things. And I'll never forget, I went and I was studying with some friends, just trying to keep my mind busy. And the neonatologist called and said, you need to get here. We found a brain bleed, a grade 2, almost grade 3 brain bleed. And my heart just dropped. And so luckily that bleed, that it cleared on its own, but it caused something called post-hemorrhagic hydrocephalus, where due to the scarring in her arachnoid villi, basically the area that drains your cerebrospinal fluid, it got scarred. So then that's when these babies develop post-hemorrhagic hydrocephalus, where she couldn't drain the fluid around her brain. So her head circumference kept increasing. She kept having increasing spells where she would just stop breathing. It was very scary. So when she was just 3 pounds, I had to meet with a neurosurgeon to talk about doing brain surgery on her and inserting a a VP shunt. So she actually had 2 shunt surgeries while she was in that NICU, which was extremely scary for me. But these are some of the complications that these newborn babies can face. There's also many complications for the mom as well. This picture is a little bit graphic, but it is very important that I share it. These are my scars. These are my staples. The night after I had my classical C-section, I remember just laying in that hospital bed feeling that this baby had gotten ripped out of me. I felt like I let myself down, I let the baby down, I let my family down. I felt like my body was not good enough. And I was traumatized because the day before I had a healthy pregnancy, I was not high risk. I had just been and had a prenatal checkup the week before, and they told me everything is fine. However, they did not check my cervix because, you know, typically around that time, you're not traditionally checking. Cervix is at, 24 weeks. But they told me I was healthy. I was not a high risk at all. So to a week later, have this baby feel like it was ripped out of me, I just felt so low and defeated. And I looked at these staples and I just felt like a piece of meat. So there's a lot of physical and mental health complications that the mothers face as well. There's also a lot of social, emotional issues. But again, I was blessed that I had my husband there with me. This is my husband and son. I was up in the NICU and I came down and they stole my bed. So I had to eventually kick them out. But it was so nice to have them there. My mother was just a major, major help to me going through this journey. And also this picture on the bottom right is my medical school friends. I was again in second year of medical school. They actually came to visit me in the hospital. Now, the doctors told me, Jasmine, you need to just go on with your normal routine while your baby's here in the NICU. You can't just stare at her every single second because you'll just drive yourself insane just worrying. So they said, go back to work or whatever your normal routine is. And I said, my normal routine is being a medical student. So I would literally be in the hospital doing flashcards and studying. And my medical school friends actually came to meet me at the hospital to study with me. And that's something that I'll never forget. I can say that I had a very, very strong support system. But again, I want you to think about all of the other mothers, especially mothers of color, and particularly my research and my advocacy focuses on Black mothers and Black infant mortality rates. Is that the same situation for all of them? And finally, this is when we were getting close to going home. This was when my husband first got to meet her. He was really scared to come to the NICU because he too was scared about, is she going to live? Is she going to die? He does not like hospitals. It was very hard. So the partners in the relationship also go through some serious social emotional issues and complications. When we talk about complications of prematurity, it's life or death for the baby, but also there are many lasting ripple effects through the whole entire family. And so this was just a special picture because this was the first time he held her and she reached her little hand up to reach him, which was so special. There are increasing rates of marital problems, divorces when you have critically ill babies. And so my husband and I actually had to go to therapy during this time because we were both so stressed out. And thankfully, we're going strong. We've been married 15 years now, and I still have a big crush on him, and he does on me too. We stuck it out through this situation, but that's not the same for all parents that are going through this. This was just a special moment. When she reached 4 pounds, I was just so happy. And this was a big day when her name was on the board right here on the bottom. And then they wiped it away because this was the day that she finally got big enough to come home on New Year's Eve. So she was in the NICU for 3 months. So this is just us bringing her home. But this time in my life, I was extremely excited, but I was also so scared as well, because when she came home, she was on an apnea monitor. She was also on caffeine. So just in case she forgot to breathe, the caffeine would help her to remember to breathe. A lot of hospitals don't even nowadays, they don't let babies go home until they're weaned off of caffeine. But this was many years ago. This was almost 11 years ago, and they still sent babies home on caffeine. She also had oxygen. So I'm getting ready to take this baby home with all these complex medical needs. She has a shunt in her brain. And oh, if it clogs up, the fluid in her brain is going to build up and she could die. So make sure if she gets sleepy or has a headache, call in right away. Oh, and if she stops breathing, this alarm will go off, and go in and use your resuscitation skills and save her right in your house. It was very scary. But again, I had a good support system. I somewhat was into the medical field because I was a second-year medical student. But again, I want to ask the question for other Black mothers right here in Dane County that are in the same situation going home, can we say the same about all of them? And the answer is no. I personally had to send home babies who the mom was homeless at the time, or who did not have a strong support system or as much medical knowledge as I did. So again, all of these things are contributing to the current infant mortality rates we see. I was so blessed that my daughter got to come home. This was her on her first night home. And when I left the hospital and brought her home, something inside of me changed. And I was so thankful she was home. And I said, I am going to dedicate my career to finding ways that other babies, all babies, can have the same opportunity and come home and have this gift like my baby did. Because it was a treasure that she even made it through and came home. And I did not take that lightly, because there are other mothers living right here in Dane County that you are very familiar with, I'm very familiar with, and across the country that do not have the same story as me. This slide here represents other mothers that had babies too early, too soon, or whose babies died before their first birthday. Now, these are not patients that I met in the hospital. These are personal family and friends in my direct, immediate family. And I got permission for these pictures, that have lost babies prematurely or who died before their first birthday. And I saw firsthand the agony that caused. Now, this is just in my personal circle. Imagine all of the other moms that are having to go through this. We often look at statistics and look at numbers, but there are stories and names behind all these babies, and their lives matter. And so that is why it is so important, again, for us to do all that we can to dig into root causes of what is causing this, what are causing these inequities, and what are solutions and things that we can do to combat racial inequities in infant mortality. This is not just a medical issue, this is a reproductive justice issue. Reproductive justice is a framework for activism, and basically it combines, it splices human rights and reproductive justice as well. And the definition of reproductive justice is more than just a pro-choice, pro-life debate. It has three primary principles: the right to not have a child, which if a mother decides that, okay, that's their right. But a mother should also have a right, if she chooses to have a child, who lives and is in a safe and healthy environment. There are a lot of people who talk about reproductive justice rights, and a lot of times they focus on the right to not have a child. But for these Black women who are wanting to have a child, they're making the decision to have a child, but they're at such higher risk of their baby not even making it out the hospital or not even surviving to their first birthday. This is a reproductive justice issue that we must take very seriously. This is a human rights issue. And this is just a picture of me with Loretta Ross, who is one of the co-founders of the reproductive justice movement. And I had the wonderful opportunity to meet her a few years back, and I shared my story with her. She's doing some amazing things, and we still stay in contact from time to time. But this is a reproductive justice issue to help these babies be able to reach their first year of life and beyond, but we need to even get them to their first birthday. So I'm going to just pause here. I'm going to now move into some solutions and some of the research I'm doing and some of the things that I'm excited about as we wrap up our time together. But I want to ask the question to you, and I want you to just be reflecting on this for the rest of my talk. And also, as you go into your day and as you can continue on doing the wonderful work that you're doing in the field of maternal child health, in your personal and professional opinion, what upstream determinants of health have most contributed to these statistics, in particular, Wisconsin's current Black preterm birth and infant mortality crises? I want you to just pause and think about that. what are some things that are driving this? Because in order for us to find solutions, we have to get to root causes. So on my journey to discover the answer to that question, after I finished my pediatrics residency, I was going to go into neonatology because I said, oh, my daughter survived. I'm going to be a neonatologist. But then I found out about a board certified medical specialty called preventive medicine and public health. And this is me with my preventive medicine cohort and advisors, and we called ourselves the public health defenders, and we were trying to be serious on this picture. But I was drawn into this field because I wanted to find solutions before the babies even reached the NICU. I wanted to be able to be a time traveler and go back in time to find out, why is this happening to Black women? What things can we do? And even before they're pregnant, what things are playing a role in this? Because our infant mortality crisis is due to complications of prematurity. Why is this happening, in particular to Black women? Now, I talk a lot about Black women in this session because that is my area of research and advocacy, but the other inequities that we see are important as well. But the focus of my research and my area of expertise is focusing on the Black infant mortality crisis. So that is what kind of shaped my career path to become a board certified, not only pediatrician, but preventive medicine and public health doctor. So let's dig into this a little bit more. There's a lot of research on this, and this is, I can have a whole grand rounds just on the research about the pathophysiology of what's going on. But just broadly, a lot of well-known researchers have made a theory called the life course perspective, where African-American women over the course of their entire lives, and even lives of their mothers and grandmothers, faced more risk factors over a life course that can contribute to their birth outcomes compared to white women who have less risk factors and more protective factors. Also, this graphic here is from County Health Rankings model, and it basically shows that only 20% of health outcomes are based on what happens in the hospital and clinics. The other 80% is based on social and economic factors, health behaviors, and one's physical environment. And racism, I would say, is something that goes on in the physical environment as well. So I got mad when I first saw this County Health Rankings model, because I said, I've been in school for 20 plus years to become a doctor, and you're telling me what I do only impacts 20% of birth outcomes? I was so mad because I thought being a doctor could impact people's lives in a tremendous way. What we do is important, but it's only 20%. If I send a family home with a prescription, but when they get home, they can't afford it, or they're fighting to even stay in their house, or they have domestic abuse situations, or they're trying to take care of their whole family, they can't focus on that medical advice that I gave them. So what happens in the hospital and clinics is only 20%. Has an impact on people's birth outcomes. So we must look and impact all areas of their lives. Some other key contributing factors to our current infant mortality crisis. This was an engagement done by the Dane County Health Council in collaboration with the Foundation for Black Women's Wellness. And they found that after they interviewed over 200 Black women right here in Dane County, they noted that racism, discrimination, and institutional bias, as well as bias and cultural disconnect in healthcare delivery experiences, is one of the #1 things that Black women are saying is contributing to these poor birth outcomes. In addition to things that were already known to us: chronic stress, difficult to navigate healthcare systems, just a lot of social economic factors. But the thing that rang out the most was their experiences with the healthcare system. Now that's where we come in, and those are things that we can really fight and advocate for. If you can look at this link down here, tinyurl.com/saving our babies report, please, somebody put that link in the chat. I highly recommend every one of you read that report from start to finish, and you will get a good understanding of what over 200 Black women have said about what things we can do to improve Black maternal child health. I recently talked to the founder of Black Women's Wellness, and I told her I was doing this talk. She said, please tell them all, every single resident, trainee, faculty should read this report, mandatory from start to finish. And we actually have some pediatrics residents going through newborn nursery where that's one of the readings in for them to look at. So I highly encourage you to read that. Other key contributing factors, hey, it's Black History Month. Let's just do a little bit of Black history. J. Marion Sims, who was a 19th century gynecologist and the founder of modern gynecology, experimented on enslaved Black women, didn't use anesthesia because he felt that Black women felt less pain. There's actually studies that show medical students who were surveyed, some medical students also thought that Black people felt less pain. This has had a lot of ripple effects through history, and it still contributes to some of the distrust that Black women have with the healthcare system. And that, oh, I can do a Black history lesson about distrust with the medical system for hours and hours, but this is just a little bit of a key contributing factor. There's a lot of distrust with the healthcare system. Also, we see that Black women the number of Black women who receive late or no prenatal care is much higher than white women. And I participated in a research study where we looked into that a little bit more. And basically what came out of that was that we need to look at whose definition of quality of care we are thinking about. What we did was we interviewed 20 Black women and then 20 OB-GYN providers. And what we found was that the OB-GYN providers, when we asked them what defines quality of care, they mentioned things like following the most recent ACOG recommendation, having timely visits, being on the cutting edge of technology was what was quality of care. But the Black moms, what they rated the highest was don't judge me, don't discriminate against me, spend time with me, communicate with me. That's how they defined quality of care. So if we're working to increase our uptake of prenatal care, especially for Black women, which we know impacts their eventual birth outcomes, we need to critically be thinking about whose definition of quality of care are we focusing on. Another recent article that I just co-authored, we looked at the WISH data in Wisconsin, and basically it just confirms some of these other findings that complications of prematurity is what's driving our Black infant mortality rates, and there are higher rates of SIDS and accidents that are contributing as well. And so that's something that we need to look into as well. But again, that is tied into many social determinants of health. And I have some forthcoming publications coming out, which is interesting. And even though we actually are just submitting this to a journal, but I wanted to share it with this audience in particular, because we analyzed PRAMS data from over 11 states. And we found that women who experienced racial discrimination during their pregnancy had higher rates of postpartum depressive symptoms. So this is something that is very important, the connection between racism and then even things like postpartum depression and things that we advocate for people who provide postnatal care screen for, not just depression, but ask them about what their experiences of racism over the course of their lives. My current research that I'll just briefly share with you before we close today, which I'm super excited about, includes combining 3 models that have shown promise for combating racial inequities and infant mortality, combining doulas, community-based doula programs, group-based models of prenatal care, such as centering pregnancy, and then also interconception and prenatal support groups. So this grant, we basically created something called the Today Not Tomorrow Pregnancy and Infant Support Program, led by Black doctors, Black doulas, other community mothers. And we brought all of these powerful forces together to create a monthly support group to support Black moms and rebuild trust. And so I'm so excited to just briefly share with you some of the preliminary findings before we close today. We basically interviewed one-on-one interviews with Black moms during pregnancy, 6 weeks postpartum and 6 months postpartum. So we followed them longitudinally to really get a in-the-moment snapshot experience from them as a Black woman navigating the healthcare system, what their experiences were, and what things they wish we could do to improve our current maternal child health situation here in Dane County. We also held a few focus groups with just any Black moms over 18 in Dane County. And we also took ethnographic field notes. And so the grants period is not over till later this year, but I want to just briefly share with you some of the preliminary findings. We have an amazing collaborative team. We're working with the Harambe Village Doulas, Today Not Tomorrow Pregnancy Family Support Center. We're working with different nonprofits in town. And I want to give a huge shout out to Dr. Kristen Sharp. She's my medical bestie, and she helped support me so much with this project and entered me into the world of centering pregnancy. So we did not do centering pregnancy with this group, but we took some of the best elements of centering pregnancy to form this culturally relevant and tailored curriculum for this new model. So I love Dr. Sharp. If you're watching, shout out to you. So I'm going to just preliminarily share these findings before we close. And this represents the voices of 25 Black women that I have intimately worked with over the last year or so. And this is what they wish that all doctors and healthcare providers would know. They mentioned a lot of things, but one of the biggest things that they mentioned was a need for more healthcare providers who look like me. So there's an outcry for a more diverse healthcare field. They also had a need to feel heard, respected, and believed. So if anything you take from this conversation, please listen to and believe Black women. And they also had an outcry for their basic needs being met. They also, some recurring themes that we've been seeing is that they wish that people would acknowledge the inequities. If anything, again, you hear from this conversation, Black women's voices are asking the OB/GYN field, don't just be nice to us when you walk in the room. I want to know that you know about all these inequities that exist, and let me know that you're going to do everything in your power to make sure I'm not one of those statistics. It's not enough to just be nice to me. Address the elephant in this room and talk to me about racism, talk to me about these inequities, and let me know that you know. Also, they want not to be judged, and they want us to treat angry Black women or frustrated Black women the same way that we would treat a white woman with tears. And they want space to heal. So they also gave us a lot of suggestions about how to form the Today Not Tomorrow Pregnancy and Infant Support Program. And they also had a lot to say about breastfeeding and ways that we can enhance and support that. So watch out for my upcoming publication later this year or into 2022, because I'm going to be publishing all of this data. Or you can invite me back because I can talk about these findings. This research study is still ongoing. There's a lot of women who are fearful of delivering in the hospital because of COVID. They have a lot of fear about the healthcare system already. And so after these inequities with COVID, they're even more hesitant to come in. And then finally, related to racism, one woman said, I love being Black, but it's just exhausting. And they vocalized a need for a safe space of support. So with their feedback, we created this monthly support group. We got to be in person for 3 months, and then COVID hit. And then we turned virtual. So we're still going strong virtually. And I have a link at the end to let you know if you want to invite any moms. It's still ongoing. So I like to always end on a positive note. So some promising initiatives that are going on. There's a birth equity collaborative that I'm a part of that we're working with the state government to pass a lot of policy initiatives. There's the Saving Our Babies campaign led by Dane County Health Council in collaboration with Foundation for Black Women's Wellness. I'm a part of that. There's a lot of exciting things going on. Governor Tony Evers just created the Governor's Health Equity Council. Harambe Village Birth and Family Center raised a lot of their initial money so that they can build an independent birthing center here in Dane County, which a lot of moms have been asking for. Life Course Initiative for Healthy Families has been doing a lot of great things. I'm on the advisory board for the Madison Center for Black Excellence in Culture that's getting ready to be built and just received $250,000 from the county. So I'm excited about that. The Black Maternal and Child Health Alliance launched. A lot of these talks, we talk about the negative, but I'm just going to blast you with some positive news as we close. Felicia Turner Walton is a Black mother and doula who lost a baby before 1 year of life, and she just got her 5013 status to be a culturally relevant service that cares for Black women who have had babies who die. So make sure to connect with her, healingourhearts.net. And we are doing a lot of work with children in the community interested in medicine. So we're adding diversity to the healthcare field. A new fund just got started with the Wisconsin Medical Society. We have a White Coats for Black Lives chapter so that we can focus on saving Black lives. So in closing, this is my last slide right here. I just want you to go away thinking of these reflection questions in your heart, and also knowing that you have the power to help join me and join many others in this fight to combat racial inequities and infant mortality. This is just the beginning. So invite me back, because as you can see, I have a lot to talk about. We got started late due to the tech issues, so we're going to wrap it up now. But please know that I'm a resource. Let's connect and collab. And I challenge and encourage all of you to get even outside of the clinic walls to make a change, because if we do this together, we can truly make a difference. Thank you so much.
Jasmine, I feel quiet. You are amazing. Your work is amazing. The presentation was awesome, and you are going to get invited back. You know, partnering with you is just mission critical for the department. And I'm sorry about the tech issues. We only have time for, does anybody have any comments or quick question? You know, we've only got 1 minute, but she'll be back. I know she will. There's a lot of comments in the chat that I think you should read, Jasmine. We appreciate you. And, you know, I think we got to go to work, but sister, we're on this with you. Thank you.
Thank you so much for having me. My email address is jzapata@uwhealth.org. So I just encourage you, send me any comments or questions you have, and we can talk about them, and any collaborations I'm happy to do. Thank you for all your incredible work that your department is doing. I know you all are doing a lot, and let's work together to make a change. Thank you so much.